the left main intervention is now very popularly done all across India. So it is important for us to understand where to do it and where not to do it. And what particular technique, what particular approach we should use while during the procedure. So main thing is during the procedure and long-term result, both should be equally good and effective to the management of the patient so that he has a long-term good survival and prognosis is good. So left main being a very big artery, large area of myocardium under jeopardy. So time that we take for the procedure should be limited, that is one thing. And to prevent complication, we should be careful in using all the devices that we are using. And technically, it's a challenging subset, we all agree. And long term, we have to look forward that there is no under-expansion of the stent which will lead to thrombosis or restenosis ISR. So while selecting a case, we should follow certain criteria and select an appropriate case which is indicated for left main PCI. And that appropriate case should be, or a patient should have an appropriate good LV function, syntax score should be up to 22 or 22 to 20, up to 30 or maybe 33. And the most important thing, no calcification, no thrombosis, large RCA to support the left main occlusion while doing the PCI, and long left main. These are some of the criteria which favor the left main PCI. And then there is a high risk PCI which is only meant for cheap operators who can do they are very expert, they can do these cases extremely well, and those cases should be left to them. This requires advanced treatment with calcium debulking and proper imaging to use various kind of tool for calcium debulking. So as I already clarified, EBC consensus, EBC precedent is here, and his consensus is the left main disease involving both the branches, stent technique should depend on individual patient's anatomical consideration or characteristic and operator skill. Both are very important, but provisional is most effective, and it is very clearly saying that compared to two stent, LMCA bifurcation is associated with single stent crossover, more favorable outcome, lower MACE rate, death rate, MI, stent thrombosis, and target vessel revascularization. Therefore, provisional one stent approach should be preferred in LMCA PCI. Now, there is true bifurcation and the non-true bifurcation. When it is a true bifurcation, if we have Medina 111, 101 and 011, these cases are ideal cases for two-stent strategy, and if you have an upfront two-stent strategy, then decay crush should be a preferred technique because that gives better long-term results. And if it is non-true, then provisional is ideal provided the angle is favorable. Now there are certain things that also dictates what kind of technique we should use. If we have a left main bifurcation having LAD, LCX, angle more than 90 or 90 more than 70, then we can consider a one provisional stent crossover if there is no significant disease in the circumflex. If we have another subset which anatomically very suitable for V-stenting, that is the side branches, the daughter branches LCX and LAD are of equal sizes. That favors V-stenting if there is a landing zone available in the left main. Then third is one provisional crush technique, which is preferred if the LAD and LCX sizes are not equal, or LCX is smaller or LAD is smaller than one of the other branches. And then of course they all left main, LAD, LCX, all of equal size, culotte is preferred. Now when we choose the stent, we choose the stent as per the daughter vessel reference diameter. And so that we should choose a stent which has the ability to expand by 2 millimeter minimum, because left main diameter is higher than the daughter vessel diameter. This is a very important thing that one should remember. Now, most stents which are available are technically possible to expand by 2 millimeter, barring few. So, ABC ethos is keep it simple, limit the number of stents, respect the original bifurcation anatomy, try to reproduce it, aim for well opposed and well expanded stent with limited overlap, and elective treatment of bifurcation lesion with complex anatomy, diffuse atherosclerotic disease, involvement of both main vessel and the side branches usually requires two-stent approach. Now, there are certain favorable criteria and non-favorable criteria which we should keep in mind so that we use appropriate strategy and use appropriate criteria to do a case which should be simple, one stent crossover. If it is required, two stent may be required, and sometimes 30% of the patient where we do a crossover, we may require a bailout stent in the side branch. Now, angle, as I said, is very, very important. If angle is acute and if you do crossover, then you are likely to have a carina shift and the closure of the side branch, acute closure of the side branch, which may lead to hemodynamic instability while doing a procedure. So you have to be very careful in choosing single crossover stent in a narrow angle. In wide angle, no problem, provided there is no significant disease in the side branch. There is another thing that even if we successfully do two stent strategy in the narrow angle, bifurcation of the left main, then also we have a trouble with the long-term fatigue of the stent at the carina. Another thing, while doing a procedure, wire wrap should be avoided, and the best technique is angulated branch should be wired first, and then you wire the LAD, perhaps that is the least angulated branch in most of the patient, and there use minimum wire rotation so that there is no wire wrap, and we all use a towel to keep the wire safe so that it doesn't rotate, the second wire doesn't rotate on its own. Now, when we do a single crossover stent, we may have the side branch occlusion for that matter, and we need to do a kissing balloon. If you need to do a kissing balloon, then must ensure that your wire is going through the distal stud, not through the proximal stud, to obtain optimal result and good opening of the LCX ostium. So we use a technique to make it sure that we should use imaging, and imaging with 3D OCT is very, very helpful in deciding whether it is a proximal stud entry or distal stud entry. The FFR is very helpful in deciding whether, even if there is small pinching of the side branch, to decide whether it is physiologically significant or not. We should do a FFR and then take a call whether to do a second stent or not, or do a kissing balloon or not. Now, when you do a kissing balloon, you should follow certain criteria which are very important. The balloon size according to the distal reference vessel, one, short balloon, non-compliant balloon, side branch first and then simultaneously. The side branch first is very important, so that you crush all the metal which is into the side branch. Use a high pressure first in the side branch, deflate it, and then do a simultaneous kissing balloon technique. That helps a lot in producing a circular lumen, which is very helpful in providing good long-term result. And when we compare the data of one strategy over the other strategy, the decay crush gives even better result than the provisional. That is something very, very much important to note. Doing imaging is very important while doing a left main case, particularly all 100% imaging cases should be done when you do left main PCI, whether it is provisional or it is two-stent strategy, because the results are phenomenally different and way better, 50% better miss rate and death rate are also 50% better in long-term result. So in decision making, tomorrow AI-based imaging may help us guiding whether side branch is, what is the value of side branch, whether it requires 2 stent or 1 stent. So we are sure that artificial intelligence will help in this regard. Even evaluation of data, it helps the bifurcation data, whatever angioplasties have been done, data can be evaluated by PCI. So PCI is a valid alternative to CABG in patients with left-main disease with low and intermediate syntax score. Provisional technique should be preferred strategy, mostly in the non-true bifurcation, and true bifurcation, true stent strategy is preferred provided there is significant disease in the side branch. Imaging is mandatory, and use of dedicated large size vessel stent are very important, which can expand more than 2 millimeter if the need be, if there is disparity in the size of the daughter branch compared to the main vessel. So in conclusion, the stent treatment for true bifurcation, left main coronary stent is safe, low stent thrombosis, and good long-term result, low MACE rate, low death rate, good prognosis. Provisional versus 2 stent strategy, provisional should be preferred unless it is very necessary to use 2 stent strategy. And operators' knowledge, skills, and experience are of paramount importance in doing left main PCI. Thank you very much for kind attention.